HAMMER study, it's actually a very exciting early phase clinical study which tests regulated interleukin-2, THOR-707, which is designed not to have alpha IL-2 activity. I mean, obviously, and this study is actually performed in combination with Pembrolizumab or as a single agent. We also have an arm with cetuximab. However, this arm is not being presented at AACR. And the study is done in advanced and metastatic solid cancers, which don't have other therapeutic options. It's a multi-center study with multiple sites in the United States, supported by THOR-X and Sanofi, which is a Sanofi company. And what is really exciting about this approach, that THOR-X has actually a very unique approach using synthetic amino acids to design their molecules. And THOR-707 is designed a way that it actually does not induce the alpha IL-2 activity. And using IL-2 for treatment of cancer is not necessarily new. I mean, IL-2 has been around for decades, and we know it can be quite effective in certain scenarios, in certain cancers. But the problem was that the toxicity due to vascular leak syndrome and was actually quite substantial. And so this one is an attempt to design the molecule which still would have advantages of IL-2 as a strong stimulating agent to induce the cytotoxic T cells infiltration and NK cell infiltration without the downside of causing actually elevation of IL-5 and consequent eosinophiles and consequently vascular leak syndrome. So the study is actually testing multiple cohorts. There are two single-agent cohorts testing either every 2 weeks or every 3 weeks administration, and then we have the cohorts which use combinations either with Pembrolizumab, that's in that THOR-707 is given every 3 weeks, and as well as Pembro is given every 3 weeks, and the other cohort, the THOR-707 is tested with cetuximab. I think so far the data are encouraging. I mean, in early phase studies in which you dose escalate, I mean, it's not that frequent that you see quite a lot of activity, and I actually think this agent appears to be effective. I mean, especially in in tumors which would be considered to be immunosensitive, so in which meaning tumor histologies which normally would be assumed to potentially benefit from checkpoint inhibitors, we've actually seen tumor shrinkage, including partial responses, and that included non-small cell lung cancer, melanoma, squamous cell cancer of unknown primary, head and neck squamous cell cancer, and basal cell cancer. Some of these patients actually were previously treated with PD-1 antibodies, so that actually made it even more exciting. So altogether, we've actually treated 45 patients. Melanoma and colorectal cancers were most frequent, but there was also an attempt to enroll some challenging cancer types which normally don't respond to immune therapies, and that included a variety of sarcomas, prostate cancer, pancreatic cancer. We kind of tried to highlight few patients in whom we saw either partial response or some evidence of benefit, which perhaps was not to the extent of partial response, but was still noteworthy. And I already mentioned a patient with head and neck squamous cell cancer. That patient actually was treated with combination, but THOR-707 was given at the lowest dose level of 8 micrograms per kilogram. And that was quite actually exciting because that patient had partial response up to minus 47%. And that response has been actually maintained for 11 plus cycles, actually now 18 plus cycles. After 11 cycles, the depth of response was the best. And this patient actually had quite a lot of prior therapies, including PD-1 antibodies. And also the patient received the lowest dose level. So it's kind of reassuring that the activity was seen even with the lowest dose level. We had a basal cell cancer patient also on therapy for 17 plus cycles. Maximum tumor reduction 80%. That patient was naive to PD-1 antibodies, as checkpoint inhibitors are actually not used that frequently in this setting, but definitely exciting and potentially something which would be worthwhile to pursue. Again, this was a combination arm. Often people kind of are skeptical when you see responses with combination which includes checkpoint inhibitor, because checkpoint inhibitors are obviously effective, and there is always this obvious question: is it checkpoint inhibitor, or is your drug really adding anything? And that's why I actually think it's important that we've also seen activity in situation when THOR-707 was given by itself, and even in a setting when prior PD-1 inhibitors were used. So that was a patient with squamous cell cancer of unknown origin who received somewhat higher dose of THOR-707, 24 micrograms per kilogram every 3 weeks. The patient is on therapy for 7+ cycles, so that would be 21 plus weeks. And the patient received prior PD-1 with stable disease, and we observed confirmed partial response, 31% reduction in tumor size. So it was a nice validation of the concept that even by the single agent, the THOR-707 can be effective. We've seen some interesting results also considered immune sensitive. It would be prostate cancer. That was not a PR. It was about 24% reduction, but I think PR is 30+% reduction. So I think 24, 30, I don't think it's that far apart. And and that was with THOR single agent without Pembrolizumab. So we also seen some minor response less than PR in non-small cell lung cancer previously treated with checkpoint inhibitors. We present quite rich biomarker data, which actually include multiple pharmacodynamic markers. And we do see actually the substantial change. We do see what, thankfully, we were expected to see and we were hoping to see. So we do see dose proportional increase in cytotoxic T cells as well as NK cells, but it doesn't seem to be followed by dose proportional increase in things which we don't want to see increasing, such as eosinophiles or regulatory T cells, which otherwise with normal native IL-2, the regulatory T cells would likely go up. We also don't really see much of detection of IL-5. On the highest dose level which we present, which is 24 micrograms per kilogram, we do see some marginal elevation of IL-5, which is barely right above the level of detection, but all the previous dose levels, actually the IL-5 levels were below the level of detection. The data for some other cytokines, such as IL-6 and cytokines, they are a little bit more diverse, but there doesn't seem to be necessarily any trend which would point out to the proportionally cytokine-driven events. The pharmacokinetic profile seems to be very clean, with the dose proportional increase in the levels in the system. And the toxicity profile is somewhat expected. A lot of AEs, adverse events, which we see are kind of acute, which happen within the first few hours or maybe first few days to a certain extent. And they include flu-like symptoms, which include fever, but we also seen hypotension. There is a little bit of struggle which we have, because some of these symptoms can resemble cytokine release syndrome, but it hasn't been always matched with the corresponding increase in cytokines when we check them in the serum. So even though the clinical manifestation might be somewhat similar, the question is it really the cytokine syndrome in the sense which we would kind of understand from some other therapies, such as CAR T cells. Even though these symptoms happened even at the level of grade 3, and we had one episode of grade 4, these events were actually responsive to therapy and did not actually necessarily prevent us from the dose escalation. In fact, the study is still proceeding with the dose escalation beyond the doses which we are presenting in this poster. So I think it looks like an exciting therapy. We've seen a decent amount of activity in both immune naive and immune pretreated cancer with both monotherapy and combination therapy. And even if the immune mediated or cytokine mediated events become more problematic with the higher doses, I think it's very reassuring that we see activity even on the lower doses. So sounds like the drug will probably have a wide therapeutic index.